it will be a good idea to show you guys how I present. This was a requested video to present to you guys or show you guys how I present to the doctors, and I'm like, oh, that's a wonderful idea. So basically I just created a quick, I'm looking at my paper, I just created a quick little case so I could run through it, so just so you guys to see exactly how I do it. Again, fake case, just made it up. So this is Bob. He had a baby. It's a boy. He's a 49-year-old male. History of hypertension, COPD. Uses supplemental oxygen at home as needed. Presenting here with dyspneic on exertion. Reports symptoms started 3 days ago. Progressively worsened, requiring his 2 liters of oxygen throughout the day. He does report he's unable to walk a few steps without feeling short of breath. He tried his nebulizer at home with no improvement, so he presented to the ED. He denies chest pain, but reports a reductive cough for 3 days. With thick green sputum, no fever or chills, denies history of PE, DVTs, no leg pain or swelling. In the ED, he did receive a nebulizer and Levoquin. Vitals are stable. He's 98% on 2 liters. Exam, lungs with expiratory wheezes throughout. Chest x-ray was non-acute. Influenza A and B was negative. BNP was normal. D-dimer was negative. Checks chemistry within normal limits. Creatinine stable. H&H stable. So this is Bob. He had a baby. It's a boy, 49-year-old male, history of hypertension, COPD, presents with dyspneic on exertion. Problem number 1, COPD exacerbation, chest x-ray negative, flu negative, D-dimer negative, BNP negative. Receive Levoquin in ED, will continue. Will start a prednisone burst times 5 days. Scheduled Q6 nebulizers, purine albuterol, Mucinex BID, will obtain a sputum culture and continue supplemental oxygen as needed, and will continue to monitor for response. So that is how I present. That's how I present. That's typically the speed at how I present. Sometimes I could go a little bit faster, especially if I'm presenting more than one case at a given time. So because the doctors there, they have to hear my cases and hear me present my 3 to 4 patients, and they also have to hear the resident present to them their admissions they do during the night. I was actually told the reason why we present this way, because this is how they think. This is how they were learned to think it through. So, and which makes sense to me. So first thing is the patient, their age, their history, and then we're talking about basically, in nursing we learned the PQRS. So their chief complaint, the shortness of breath, and how did it start? 3 days ago, progressively worse. It's worse when he takes a couple steps. He tried his nebulizer with no improvements. He does have a cough to suggest, yes, it may be, COPD exacerbation with, the thick green sputum. There's no fevers or anything like that, so okay, we could think that there's no other infection that may be causing it, like underlying pneumonia or like influenza. Check if he had like a history of DVT and PE to make sure there's like no blood clots, and then just going through the rest. His vitals were stable. I told him what he was sat at, on his 2 liters. He's fine. Told him how his lungs filled signs. So it's like, so we're focused on his shortness of breath. So it's like the lungs, and we're trying to rule out other things, rule out PE, D-dimer was negative, rule out flu, influenza was negative, chest x-ray didn't show any like infiltrates to suggest or consolidation to suggest. Gosh, my throat and my voice. I might not even post this and do it when my voice is not this raspy. But anyway, so when I ran through the whole thing, I didn't give any of my opinions as to what could it be until the end. And so I reminded the attending again when I restated the patient's name, their history, why they're here, and then I went into the problem list, which problem number 1 was COPD exacerbation. But anyway, this is how they think, which I understand now, and I get it, especially when we're busy, like running through that. They're like, cool, I think it's this, I think it's that, and just going by that, they could, and what are the details that I give them, they're able to just say, hey, yeah, that's COPD exacerbation. That's exactly what it is. Just going by, and focusing on the pertinent things. But that would all come when you become a nurse practitioner and when you get experience focusing on the pertinent things. And just for example, no history of PE DVTs. He denies leg swelling or leg calf swelling or any pain in his calves, because obviously if there's some pain there's some swelling, we want to think DVT. Do we need to check a Doppler just to rule out he doesn't have a DVT, that he may be possible have a PE? But anyway, This video was basically just how I present. So like it, subscribe, you know what to do. Again, leave a comment with any suggestive video topics because I will get it done. I will find the time and get it done, like I did this one because it was requested, I think, today, and I was like, that was a good, hey, I didn't even think about doing that, and I just gave it to y'all. So until the next video.